So hello everyone and welcome to this finals crash course series on psychiatry, and this is part 4 of our psych teaching. If you want to follow us on Instagram, see which sessions we've got coming up, there's a link there in the top right hand corner, and on the bottom left there's our email address if you want to get in touch about any questions about our teaching or if you want to get involved yourselves. And today's session will be taught by Sophie, who's currently working at Ealing Hospital. Sophie, I'll hand this over to you. And I'm just going to also pop a link in the chat. So this is our polls app. So if you join on the VBox, you can interact with some of the questions as well.
Perfect. Thank you, Ellie. So yeah, as I mentioned, my name's Sophie. I'm currently an F1 and my first job was in psychiatry. So I'm hoping that I've learned a few useful things that I'll be able to kind of impart to you guys today. I'm going to turn my camera off because I've got notoriously bad internet. But if for any reason the connection's bad, if somebody just drops a message in the chat, hopefully it's fixable. So yeah, today is part 4 of the psychiatry series. So we'll just kind of be tying up some of the loose ends that we haven't covered in the other sessions. So the subjects that we'll be touching upon this evening are alcohol, misuse and drug abuse. We'll look a bit at personality disorders, eating disorders, and then to finish off, we'll also look at some of the functional disorders that generally seem to fall under the psychiatry umbrella when we're thinking about finals revision. So if we kick off with our first question for this evening then, you are a 4th year medical student on placement in an alcohol rehabilitation unit. You're asked to go and take a history from one of the patients and present this back to the consultant. The patient you take a history from tells you how she used to drink 2 bottles of wine a day, lost her job as a result of her drinking, had to drink first thing in the morning on account of waking feeling shaky, couldn't stop drinking once she started, and found that she was having to drink more and more to get the relaxed feeling that she'd come to rely upon alcohol for. So which of the following present in this patient's history is not considered to be a feature of alcohol dependence? And I'll just give a few minutes to have a read through of that and for any answers to come through. Okay. So the correct answer for this question is E, drinking over 35 units a week. So we'll just think a bit about then harmful use of alcohol and alcohol dependence. So there's different kind of words that can be used to describe patients who are perhaps drinking more alcohol than they should. And the first is hazardous drinking. So this describes a patient who is engaging in a pattern of drinking that will eventually cause harm, but perhaps hasn't yet caused harm. So these could be our patients who are drinking more than their, say, weekly limits of alcohol. We've then got harmful drinking. So this is where you've got somebody who has been drinking hazardously, apart from whereas with hazardous, it was kind of hypothetical that this could cause harm. With harmful drinking, this patient is now starting to see some sort of physical, mental or social damage. And then the next step up is when we think about dependent drinking. And there's a number of criteria that can be used to define dependent drinking. So we're looking at somebody who is repeatedly using alcohol. They've got a strong drive to use alcohol and they're unable to control their use of alcohol. They're giving priority to alcohol and drinking that over other activities, despite the fact that there may be negative consequences to it. And we can also see that these patients have started to develop feelings of urges or cravings to drink alcohol, and they can also have physiological features, so that might be tolerance or withdrawal. And generally when we're thinking about giving a diagnosis of dependent drinking, we're thinking about some of these features being evident over a period of at least 12 months. However, if you've got somebody who is using alcohol daily or almost daily, then actually having that sort of pattern of behaviour present for 3 months means that we can think about giving a diagnosis of dependent drinking. So just linking back to the question then, we could see that our patient was showing a lot of these signs, and the reason that the answer was drinking over 35 units a week is that actually alcohol dependence, they haven't put a set amount of alcohol you have to be drinking in order to have a diagnosis of alcohol dependence. Obviously, our 14 units per week is kind of what's recommended as within the healthy limits. But when we're thinking about kind of giving somebody a diagnosis of alcohol dependence, there isn't actually a set number of units that a patient needs to be drinking to correlate with that. And one of the tools that we can use to help identify patients who may be drinking at harmful levels is our audit score. As obviously it's really important to kind of identify patients who are drinking too much due to the negative consequences this can have on their health, and obviously preventing that from happening. So when we think about who's at risk for developing alcohol dependence, there is a genetic component to it. So there's an increased risk of dependence among relatives of already dependent individuals. Likewise, there can be some things that have actually happened very early on in patients' lives which might increase the risk of dependence. So if there's been intrauterine exposure to drugs or alcohol, if they've had psychiatric problems in childhood, perhaps a history of trauma or low level of education, these are all known to be risk factors for developing alcohol dependence. And then, of course, we can look at things such as people who are drinking steadily over time, or people who are binge drinkers, are also at increased risk. And what generally seems to happen is there is sort of positive reinforcement for somebody using alcohol when they get the pleasant effects of alcohol. So that might be feeling more relaxed, able to socialize more easily. And then we also have negative reinforcement, which occurs with the symptoms of alcohol withdrawal. So when you've got somebody who has been drinking so much that they, are now getting withdrawal symptoms when they stop drinking, that negative reinforcement is going to combine with the positive reinforcement of feeling good whilst they're drinking to make it very difficult for them to actually stop drinking. When we're thinking about taking a history from somebody with an alcohol dependence, or really any kind of substance dependence, there are a number of questions that we want to make sure that we're asking. So the first is looking at the current use of whatever substance they're using. And we can use the mnemonic TRAP, which stands for type, route, amount, and pattern, to kind of give us some insight into that. We want to be asking if there's any evidence of dependence, so going through that criteria previously mentioned, if there's any tolerance, withdrawal, craving, and trying to work out just what level of impact this is having upon their activities of daily life. And also thinking about complications of drug or alcohol use. So if, for example, you've got somebody who is an IV drug user, we want to be thinking about perhaps whether there's, are they somebody who don't use clean needles, and therefore are they at increased risk of bloodborne viruses, for example. We then want to think about past use and general history in terms of alcohol and substances. So have they previously tried to stop using whatever it is that they're addicted to? Have they gone through a detox program? And then, as we do with all of our histories, we want to make sure we're covering general past medical history, family history, social history, and sexual history. And the final thing that can be quite important to do is think about future usage. So when we're sort of presented with a patient who's got some sort of substance misuse, we want to think, how likely is it that this patient is going to be able to stop using whatever it is they're using? Are they somebody who recognizes that their current use is a problem, or are they someone who perhaps isn't yet ready to start taking those steps towards ending that harmful behavior? So if we move on to another question then. So you're an FY1 clerking as part of the medical take team. Your next patient is a 47-year-old male who is presented with jaundice and abdominal pain. Whilst taking your history, the patient tells you he drinks a bottle of whiskey a day and has done so for the past 2 years since losing his job. He last had a drink at 10 AM this morning before he came to hospital and is currently feeling shaky and sweaty. Which of the following pharmacological agents would be appropriate to prescribe the patient whilst he is admitted to hospital? Okay, so I'll just give a few seconds for that one. And the correct answer there is B, chlordiazepoxide. So when we've got somebody who is drinking too much alcohol, then obviously they are at high risk of alcohol withdrawal. And we can see kind of different groupings of symptoms of alcohol withdrawal depending on how long it's been since the patient has last had a drink. So between 6 to 12 hours after their last drink, we can see symptoms such as tremor, sweating, tachycardia, anxiety, nausea and vomiting, mood disturbance, hyperacusis, sleep disturbance, and psychomotor agitation. When we reach the 36-hour mark, this is when we've got our peak incidence of seizures, and obviously that's something that we need to be really alert to and trying to prevent. And then between 48 to 72 hours, this is when we have our peak incidence of delirium tremens, which is kind of a group of symptoms including coarse tremor, confusion, delusions, hallucinations, fever, and tachycardia. And we mentioned earlier how there are some scoring systems that we can use to identify patients at risk of alcohol dependence. And likewise, we've got scoring systems that we can use to assess the severity of withdrawal. And this is where our CWA score comes in. And actually, the CWA score is quite useful because it has quite a direct impact upon what we're going to do in terms of treatment. When we think about the management of acute alcohol withdrawal, as was mentioned within the question, we want to be giving our patients benzodiazepines to help with that process. And this generally tends to be chlordiazepoxide. However, there might be some variation in which hospitals will use what benzodiazepine. It's also really important when somebody has been admitted to hospital and is undergoing alcohol withdrawal that we think about giving them thiamine supplementation. So this is also known as Pabrinex and is the bright yellow stuff that you'll see hanging up in the drip bags. And this is because patients who drink excessively are at high risk of thiamine deficiency. And if that kind of goes unnoticed and untreated, then that's when you can start to develop things such as Wernicke's or Korsakoff's, which obviously we want to prevent. When we're thinking kind of more long-term, looking forward, when we've got a patient who is exhibiting alcohol dependence and we want to help them kind of stop that, then obviously there's a large part of that role is played by psychoeducation and motivational therapy. So there's lots of different sort of programs. So there might be some that are perhaps more based upon CBT. There are 12-step programs. And then kind of the final part of management for long-term alcohol dependence is some other medication. And so these were some of the options that were kind of shown in the question. So these are things such as disulfiram, naltrexone, and acamprosate. So just to talk a little bit through about what each of those are. So disulfiram is also known as antabuse. So it basically inhibits the enzyme acetaldehyde dehydrogenase, which would normally be responsible for breaking down alcohol. And that basically means that you sort of immediately feel the hangover effects as soon as you've drunk alcohol. So it gives patients a very immediate, nasty feeling. And obviously that should hopefully deter them from further drinking alcohol. Naltrexone and acamprosate work slightly differently. So these are anti-craving medications, obviously preventing the patient from actually having that craving and wanting to use alcohol in the first place. And when we're thinking about which patients perhaps might do quite well in terms of undergoing detox and managing to stay sober, it's things such as being in a stable relationship, employed, and having stable living conditions that are all going to help with that process. So likewise, if we've got somebody who perhaps doesn't have these things, then it can be a lot more difficult to achieve complete abstinence. So if we move on to question 3. A 27-year-old male is taken to hospital following a seizure which lasted 2 minutes. This is his first ever seizure, and his partner states he's been losing weight but is eating well. He's had episodes of low mood, paranoia, and has passed some concerning comments about ending his life. He's also had recurrent nosebleeds. On examination, he's hot, clammy, and very drowsy. His chest is clear, but he's got some mild abdominal tenderness, and ECG shows sinus tachycardia with a heart rate of 125 beats per minute. Which of the following substances do you think is most likely to be causing this presentation? So that's A, cocaine, B, heroin, C, alcohol, D, cannabis, or E, ecstasy. Fab. And the correct answer there is A, cocaine. So it's quite useful to just kind of know some of the common signs and symptoms that can be seen regarding different substances when they've perhaps been an overdose or when we've got misuse, and they can be quite common finals questions actually. So if we think about our heroin toxicity, so our key signs and symptoms to look out for are things such as pinpoint pupils, reduced GCS, shallow breathing, pale skin and blue lips. And obviously, as we all know, heroin is part of the opioid family. So actually, if you've also got a patient who has overdosed on opioids, be this perhaps outside of hospital or even within, if they've perhaps had too much morphine or something, then we can also see those same symptoms. When we think about what tends to be associated with ecstasy intoxication, that's things like nausea, muscle cramping, tension in the mouth, face and jaw, fever, sweating and chills, hallucinations or blurred vision, tachycardia and unusual levels of energy. Our patients who might be coming in having had too much to drink tend to show bradycardia and hypertension. They might have a loss of balance, be quite restless, have slurred speech, and can also be quite euphoric, and their behaviour can just generally be quite inhibited. And with cannabis, we can expect to see things such as anxiety, dizziness, dry mouth, euphoria, impaired motor function, and increased appetite. So in our question stem, it was most likely cocaine that had caused these patients' symptoms. So we saw that they had seizures, they were tachycardic, they'd had a history of weight loss. There seemed to be some indication that the patient had been more anxious recently, and they'd also had nosebleeds. And these are all common symptoms with cocaine use. We can also see hypertension, nausea and vomiting, and hallucinations that also occur with cocaine. So it's just being aware of kind of some of those key signs and symptoms and being able to pick up on that in the stem of your exam questions. Question 4 for tonight's session then is just moving on to think a bit about our personality disorders. So a 25-year-old woman describes problems with her mood dating back as long as she can remember. She feels her mood is always up and down, loses her temper quickly, and has frequent mood swings. She often feels empty and can describe engaging in self-harm behaviours as a result. She has had frequent contacts with mental health services. So which is the most likely personality disorder that this lady might be diagnosed with? A, paranoid, B, avoidant, C, histrionic, D, dependent, or E, emotionally unstable, which is also sometimes called borderline personality disorder. And the correct answer for that one there is E, emotionally unstable personality disorder. So when we're thinking about personality disorders, it's quite useful to think about what we're actually talking about. They can be quite a kind of perhaps trivial diagnosis in psychiatry. There's a lot of talk about whether or not they actually are a psychiatric diagnosis, which is why it can be useful to know actually what is it that we have to be referring to when we've got somebody who we think might have a personality disorder. And so what we're talking about is we've got some sort of disturbance which basically impacts somebody's ability to function and kind of impacts their personality, as the name suggests. And this disturbance is present over an extended period of time, and it shows itself in both cognition, emotional experience and expression, and also behaviour. And generally, whether they're thinking, feeling, or acting in a way that's kind of different from normal, it tends to be a maladaptive way. And this way of responding to others and the world, this maladaptive behaviour, tends to be present across a range of personal and social situations. So it's not just limited to perhaps one relationship they have with a particular person in their life. It's present across all relationships they're making and across all situations they might find themselves in. Patients with a personality disorder, their symptoms can't be explained by a different medication or substance and are not better accounted for by another mental or physical disorder. Personality disorders are also associated with quite significant distress or impairment in important areas of functioning. So we've already mentioned that might be in personal functioning, that might be in the relationships they have with their family, or it might be in their social circumstance and situation. Obviously, across different kind of people and cultures throughout the world, there are some things which perhaps in one culture might be considered normal, but in another culture that would be considered quite strange behaviour. So it's appropriate to note that we can't give a diagnosis of a personality disorder if the behaviour that they're displaying is actually either developmentally appropriate for their age or can be explained by social or cultural factors. And the point about not being able to diagnose a personality disorder if they're displaying developmentally age-appropriate behaviour is why we tend not to give a personality disorder diagnosis within childhood. So although some of those behaviours relating to a particular personality disorder might be present from childhood, it's only really when we're kind of getting into late adolescence that that diagnosis tends to be given. With the symptoms being present in childhood and continuing to progress throughout adolescence and continuing into adult life. With our personality disorders, there are three main clusters that describe the different behaviours. So we've got our cluster A, which can be described as odd, aloof, or eccentric. And this takes into account our paranoid personality disorder, our schizoid, and our schizotypal. Cluster B is often referred to as the dramatic, impulsive, and erratic personality types. So these include our antisocial personality disorder, emotionally unstable, narcissistic, and histrionic. And it's just worth noting that there are some kind of correlations between particular personality disorders and other issues. So antisocial personality disorder is associated with substance misuse, and our histrionic personality disorder is associated with somatization, which we'll come to talk about later in this presentation. And finally, we've got our cluster C personalities, which are described as anxious and fearful. So this includes our anxious avoidant, dependent, and our obsessive compulsive personalities. So I've just popped up here some kind of features that can be seen in each of the personality disorders. I won't read through this right now because, as you can see, it's quite a lot of text on the slide, but this can kind of be used as something that you guys are able to reference back to in terms of your revision, as you will get access to the slides at the end of the session if you complete the feedback form. But yeah, this table just sort of talks through the cluster, talks through the disorders within that cluster, and talks through some of the stereotypical features that you can expect to see. And it's those stereotypical features that, again, you want to be looking out for in the stems of your questions to help give you a clue as to what the answer might be. So I'll leave that there for people to be able to go through in their own time. So our fifth question for tonight's session, again, we'll move away from personality disorders and now start thinking about our eating disorders. So Julia is 18 years old and studying for her A-levels. She's predicted to get 3 A-star grades and wants to study medicine. Since completing her mocks 4 months ago, she started to eat only 1 meal a day and has become preoccupied with the fact that she thinks that she looks fat. She started going to the gym to try to lose weight, although her BMI is only 17. Which of the following is Julia displaying signs of? A, OCD, B, anorexia, C, normal stress response, D, bulimia, or E, autism? And the correct answer there was B, anorexia. So when we think about our eating disorders, there's probably two main eating disorders that spring to mind, being anorexia nervosa and bulimia. And whilst there are some similarities between the two, there are also differences. So when we think about anorexia, this is a picture that is characterized by restriction of energy intake, which results in low body weight. People with anorexia have this overvalued idea that they're fat or intense fear of gaining weight, even though actually it's the complete opposite that's true. So these are actually the patients who are very underweight. And generally they have this disturbance in the way in which the body is viewed, or they kind of deny the seriousness of their current low weight and they don't view this as an issue. Bulimia, on the other hand, is characterized by recurrent episodes of binge eating, and there's a sense of lack of control whilst these binge eating episodes are happening. In bulimia, we see compensatory behavior. So they've got these binge eating sessions that they'll have, but then they might compensate by purging. And purging can refer to either sort of vomiting, misusing diuretics to prevent weight gain, misusing laxatives to prevent weight gain. And so as a result, our bulimic patients are not underweight. But they also, similar to our anorexic patients, their kind of self-evaluation and their self-worth is unduly influenced by their body shape and weight. So to summarize, anorexia is about restriction and about low body weight, whereas bulimia is about episodes of binge eating, potentially with purging, and maintaining a normal weight. Whilst anorexia and bulimia are probably the two most common eating disorders and the ones that will come to mind first, there are also another couple of eating disorders that I thought I'd mention in this presentation. So the first is binge eating disorder. So this is where you've got recurrent episodes of binge eating, a lack of control whilst eating, distress with that binge eating. And the key difference between binge eating disorder and bulimia is that in binge eating disorder, there is an absence of that compensatory behavior. So there's an absence of purging in whatever way that may be. Another eating disorder is known as ARFID, which is our avoidant restrictive food intake disorder. And so this is a little bit of an atypical eating disorder because this kind of describes our patients who perhaps don't eat enough or show very little interest in feeding, those who only accept a limited diet due to sensory features, or individuals whose food refusal might be linked to a particular adverse experience. So whereas with bulimia and anorexia, a lot of it's quite sort of image driven and being worried about, in the case of anorexia, sort of being worried about being fat, our ARFID patients, it's not to do with body image, it's more to do with actually eating itself and that kind of being problematic for the patient. So you are a 5th year medical student revising for your finals, and you decide today that you're going to be revising eating disorders. So which of the following is not considered a risk factor for eating disorder development? A, female sex, B, type 1 diabetes mellitus, C, perfectionism, D, middle age, and E, family history. So we're thinking about which one is not a risk factor for eating disorders. Brilliant. So the correct answer for that was D, middle age. So when we think about our eating disorders, there's a prevalence of about 1 to 3 in 1,000. And there are a number of risk factors that increase patients developing an eating disorder. So the first is female sex. If you are sort of younger in age, so teenagers and young adults, that's the common age group, so not middle age, which was obviously what we referenced to in the question. There's also actually some evidence to suggest that there is increased incidence of eating disorders in particular occupations. So it can be quite common in ballet dancers, it can be quite common in all-girl private schools, models, and also in psychologists. And people who display kind of traits of perfectionism are also at increased risk of eating disorders. If there's a past history of dieting or family history of eating disorders, that's also going to increase your risk. And things like type 1 diabetes mellitus, allergies, and food intolerances, they are risk factors more particularly for our patients who have ARFID, as opposed to those who have anorexia or bulimia or binge eating disorder. Again, body image dissatisfaction, history of an anxiety disorder, behavioural inflexibility, and history of having been bullied all increase that risk of a patient having an eating disorder. So sticking with our eating disorders, you are a final year medical student placed on the acute medical unit. The next patient you are due to see on ward round is a 22-year-old girl with a history of bulimia who has been admitted after self-harming, having made several deep lacerations to her wrist. The consultant asks you to check her blood work before going to see the patient. Given the patient has bulimia, which electrolyte imbalance are you most likely to see on her blood work? Hyponatremia, hyponatremia, hypokalemia, hypercalcemia, or hyperkalemia. And the correct answer to this question is C, hypokalemia. So thinking about our signs and symptoms of anorexia and bulimia then. So we've kind of adhered to some of these already. With anorexia, we tend to see a reduced BMI, so that's anything less than 17.5. We see bradycardia, palpitations, hypertension, weakness, dizziness, enlarged salivary glands, lanugo hair, and amenorrhea. In our bulimic patients, as already mentioned, these tend to be people who have normal body weight. They might have Russell's sign, which refers to kind of the development of calluses on the back of the knuckles, and that's from where patients are making themselves sick and their teeth are obviously coming into contact with that area of the skin. We also see enlarged salivary glands, subconjunctival hemorrhage, and esophageal dysmotility, with those final three symptoms all kind of coming about as a direct consequence of being sick. And the enlarged salivary glands, so that happens because if you've got somebody who is inducing vomiting multiple times a day, then there's going to be an excessive amount of saliva produced, which causes the parotid glands to become overstimulated and hypertrophy, so giving you that enlarged salivary gland appearance. So whilst they can be some of the outward signs of anorexia or bulimia, there are also a number of biochemical markers that we might see in the blood work of patients who've got an eating disorder. So we can see anemia, pancytopenia, and thrombocytopenia, and this is because we've got reduced bone marrow turnover. We can see decreased creatinine. We can see a couple of electrolyte disturbances, so hypokalemia and hyponatremia are your most common ones, and it's important to note that hyperkalemia tends to only be seen if patients are purging. And this occurs because you have obviously got some direct loss of potassium ions being excreted in the vomit or in the stool, but it also happens because when you're vomiting, you're obviously bringing up a lot of hydrogen ions, and as a result, the subsequent increase you get in pH is normalized through exchanging your potassium and hydrogen ions. So then you've got a lot more potassium that's no longer that's then within the cell, and it's not within the serum, which is obviously what you're measuring when you take your blood sample. We can also see low thyroxine levels, low FSH, LH, estrogen, and testosterone, and this is all to do with sort of decreased activity of the pituitary gland. We can see raised cortisol and growth growth hormone as a stress response, deranged LFTs and low albumin, and impaired glucose tolerance. So actually there's a number of things that's important to be aware of that you might see in the blood work of patients who have got an eating disorder. Moving on to question 8. You are an FY2 working in general practice. Your next patient is a 44-year-old woman whose 14-year-old daughter has just been admitted to hospital with anorexia. She's very tearful and has come to see you regarding the low mood she is currently suffering from. She's very concerned about her daughter and has a number of questions about anorexia, including whether it's likely her daughter will recover. What percentage of people with anorexia recover and return to a normal weight? So A, 5%, B, 25%, C, 40%, D, 50%, or E, 75%. So I'll just give some time for that one. And the correct answer to this question is D, 50%. So when we've got a patient with anorexia, then obviously we want to think about how we can help this person. And the mainstay of management is to do with sort of psychotherapy. So if you've got a child or a young person, we tend to promote anorexia-focused family therapy or CBT, whereas with our adults, it tends to be individual eating disorder-focused CBT. And there are also some specific programs that are unique to anorexia, such as Mantra. With our anorexic patients, about 50% of them recover and return to a normal weight. Up to 25% go on to develop bulimia, and sadly around up to 10% of patients will eventually die because of the disorder. And the remaining percentage left, for those who might be adding up and thinking that doesn't come to 100, are the patients who sort of remain chronically struggling with anorexia throughout their life. Some factors that are associated with poor prognosis is long duration of illness. So the average duration of illness for an anorexic patient is around 6 years. The longer this is, the poorer the prognosis tends to be. Late age of onset is also a negative sign, as is very low weight, associated bulimic symptoms, personality difficulties, poor family relationships, and poor social adjustment. So patients who perhaps have one of these factors are ones that might not do as well, and ones that might need some added support to try and achieve resolution. Our management of bulimia is quite similar, really. So again, with children and young people, it's going to be some sort of talking, psychotherapy that's going to be family related, and with our adults it's individual related. So that can be guided self-help or eating disorder focused CBT. Interestingly, with bulimia, actually there is a licensed drug that we can use. So fluoxetine, which is one of our SSRIs, is actually licensed to reduce binging and purging behavior, so that might be appropriate. And our prognosis for bulimia is a little bit better than our prognosis for anorexia. So it's around 50 to 70% of patients that recover after 2 to 5 years, whereas with anorexia, it's just around 50%. And again, some of our poor prognostic factors that we want to watch out for is patients who have severe binging and purging behavior, patients who have a low weight, and patients who have comorbid depression. So stepping away from eating disorders and moving to kind of the final part of tonight's session, and actually the final question is question 9. So you're a final year medical student on your GP placement. Your next patient is a 49-year-old male who has booked an appointment for leg pain. You know on the online note system that he has presented with this problem several times over the past 3 years. He's had numerous investigations, all of which have been normal, and there seems to be no pathological explanation for his symptoms. During the consultation, he appears quite distressed by what he's experiencing. Which of the following disorders is this patient most likely to be suffering from? A, hypochondrial disorder, B, somaticization, C, conversion, D, dissociative disorder, or E, malingering. And the correct answer for question 9 is B, somaticization disorder. So what are we referring to by somaticization disorder, which is also sometimes known as Burkitt's syndrome? So this refers to a patient who has had multiple physical symptoms which have been present for at least 2 years. There's some degree of functional impairment due to those symptoms, and the patient refuses to accept reassurance or negative test results, and they want treatment to remove their symptoms. So somaticization disorder is basically patients are feeling something, the brain is perceiving that feeling of pain as real. However, there isn't any organ pathology which we've found which is able to explain that pain. Conversely, our hypochondrial disorder is patients who believe that they've got an underlying serious disease, and that's because they're misinterpreting normal bodily sensations. They refuse to accept any reassurance or negative test results, and they'll ask for investigations to diagnose or confirm their underlying disease. So the difference between sort of somaticization and hypochondrial is hypochondrial disorder, you think that you've got something really wrong with you, some sort of deadly illness, whereas your somaticization, there is distress associated with your symptoms, but you don't necessarily think that you've got a very particular condition, which is what we tend to see in patients who have hypochondrial disorder. A couple of other options that were included within that question were conversion disorder and dissociative disorder. So conversion disorder is when a patient complains about loss of motor or sensory function. These symptoms, again, aren't consciously feigned, and these patients tend to be indifferent to their disorder, and that's referred to as labile indifference. Terrible French accent there. So our conversion disorder doesn't tend to be distressing and tends to be loss of motor or sensory function, whereas our somaticization tends to be more about pain and tends to be associated with distress. Dissociative disorder refers to when somebody kind of separates off certain memories. And so this involves more psychiatric symptoms such as amnesia, fugue, or stupor. And our dissociative identity disorder, which refers to multiple personality disorder, is the most severe form of dissociative disorder. And the final two disorders that kind of seem to crop up under this area of psychiatry are factitious disorder, which is also known as Munchausen's, and malingering. So whereas the 4 other disorders we've mentioned, patients haven't intentionally been producing their symptoms, with factitious disorder, a patient is actually taking action to induce a particular symptom. And with Munchausen's, that's because they want to assume the sick role. They want to be cared for and potentially even to be hospitalized. And Munchausen's by proxy is where you've got a carer who is inducing illness in a dependent. And then finally, we've got malingering. So this is again when a patient actually is either simulating their symptoms or they're exaggerating their symptoms. And this is with the intention of financial or other gain, such as sort of getting leave off of work or leave from school, among other things. So our factitious disorder and our malingering disorder are 2 where actually patients are inducing those symptoms and fabricating those symptoms, whereas the other 4 disorders are actually where patients are experiencing symptoms that very much feel real to them.
We've got just one question in the chat. So how is conversion disorder different from functional neurological disorder?
So that's a good question. My understanding is that it's kind of part of it. I think I've mostly kind of heard people use the 2 synonymously, but I think sometimes with conversion disorder there tends to be kind of like there might be some sort of trauma or particular event which they think might have been the trigger for that then inducing the functional neurology, is my understanding. But I'm not 100% sure on that one. And I must admit, I've always found kind of this area of psychiatry to always be a little bit confusing, trying to differentiate between all the different bits and bobs. But I hope that helps.
Thank you.
No worries. So thank you all so much for listening and for coming along to the session. If there's any more questions, then feel free to pop it in the chat. And again, I think Ellie's popped the link for the feedback form in the chat, but there's also a QR code here. We really appreciate the feedback, and you guys will get access to the slides once you've filled out that feedback form.